Good morning, Pete.
Morning. Today I'm joined by Mr. Jazz Wright. We're going to talk about urinary incontinence. So, what is urinary incontinence?
So, if we go through the sort of simplest definition, urinary incontinence is the involuntary loss of urine. Now, there are certain sub-classifications which we'll go through, and the commonest ones that everybody knows are stress urinary incontinence. So, there's usually an exacerbating increase in abdominal pressure, so a cough, a sneeze or pelvic strain, and then they have a loss of incontinence. Now they may have normal voiding in between, but its risk factors are childbirth and obesity. So the other one we talk about is urgency associated incontinence. So urge is a desire to void that you just can't defer, and if that's associated with a loss of incontinence, we call it urge incontinence. Now you can have no loss of incontinence and what we call overactive bladder, where you have the urgency, frequency and even nocturia, and you can have them with incontinence too. And you can have a mixed urinary incontinence where you have some urgency and some stress urinary incontinence. So those are the most common types of incontinence.
Sure.
There are some lesser common types of incontinence. So overflow incontinence, so we're talking about women, but in blokes you can have overflow incontinence where you're actually in retention all the time, and in men you see it with enlarged prostates, or in both sexes with neuropathic bladders really. There's functional incontinence where actually the whole voiding pattern is fine, but the patient doesn't have enough time to get to the toilet. So you see that in people with a neurological disability or the elderly and in frail. So often in care homes where they just can't get to the toilet in time. And then there's total incontinence, which usually implies either a structural abnormality, so an ectopic ureter in a female, or a vesicovagina fistula, or it could be severe stress urinary incontinence, or in a sort of neuropathic patient. And then there are the very, very unusual, or not so often heard about types of incontinence. So postural urinary incontinence, which is rising from a seated position, and that's usually when there's an urgency trigger underneath and you get a bit of a bladder contraction and a leak that catches the patient off guard. There's insensible, which is where the patient is unaware. So it may be there's underlying detrusor overactivity and you would then need to go to investigation to find this out. But the patient sometimes doesn't have warning, and that can be quite debilitating because you can't prepare for that. Then there's coital urinary incontinence, which is a newer subtopic that the International Continence Society have put on their classifications, and that's stress usually, or again detrusor overactivity, and it comes on during intercourse.
Okay. And so obviously there's an overlap between all these different sorts of incontinence. We already talked about mixed incontinence. How big is the problem?
So ballpark figure, if we're talking about females, it can affect up to a third of the adult population. Now, if you subdivide the types of incontinence, and if we look at this slide, you can see that about 30% of people will have overactive bladder, but they'll be dry. A number of those will have overactive bladder and be wet. Of the whole population, up to almost 20% will have stress urinary incontinence, and then there will be a proportion where there's an overlap, so they'll have stress and OAB and wet, or a mixture of everything, and that could be 10%, which is a large figure actually.
Sure. And urinary incontinence can happen acutely, can't it? So what are the different reasons for that?
So if you're looking after somebody on a ward or somebody with acutely well, the mnemonic is diapers, which is quite easy to remember. So the D stands for delirium, dementia or other confusional type state. The I is for infection, so urinary tract infection or respiratory infection where the coughing is actually triggering stress incontinence in someone who ordinarily wouldn't have stress symptoms. The A is for atrophic vaginitis in the postmenopausal population. P is for psychological, such as depression or other depressed states. P, pharmacological, so alpha blockers, which relax the prostate as a treatment in bladder outflow obstruction in men, can cause incontinence if given to a younger population. Sedatives, diuretics, where you're forcing the patient to produce a lot more urine than they would normally handle. excessive alcohol. Then there are endocrine conditions where you force an increased diuretic load in patients so that they have a polyuria and then they can't control that. The R is for restricted mobility, so that's back to functional incontinence. Again, that could be a transient thing, post-hip replacement, or when they're acutely unwell and they've lost some muscle mass. And the S is for stool impaction. So, diapers.
Sure. And so, how do we come to a diagnosis?
So, you're going to get it all pretty much from the history, actually. So, the pattern of voiding, day, night, what they sort of gives you an idea of their bladder capacity, the number of incontinence episodes, and particularly the triggers. So, the stress, is it cough? In urgency, is there some discomfort they need to wee? The severity, so what's their pad usage number and size of pads, and then any other associated symptoms really with this, such as urgency, bladder pain, you shouldn't really have pain when you're waiting to void, dysuria, is there a UTI, vaginal discomfort, is there atrophy, incomplete bladder emptying, are they leaking at night, have they got a distended abdomen, hesitancy and poor flow. And then in clinic and in the secondary care, in community, you use validated questionnaires, which can be quite useful, particularly to follow up the patient. So the International Continence Society produced an overactive bladder short form questionnaire and an urgency incontinence short form questionnaire. We also in clinic routinely use the bladder diary. So for 3 days they put in what and how much they're drinking. So is it tea, is it coffee, is it water, and then how much they're voiding in terms of volume, and then whether there are associated episodes of incontinence. And then as part of your history you get relevant medical history to this, so past medical history, particularly of surgery, radiotherapy to the pelvis, have they got a neuro condition, are they diabetic, have they had treatment for incontinence, and what drugs have they had.
Okay, so what are you looking for when you examine the patient?
So you're going to do a kind of focused exam really, so you're going to look at vaginally in females, you're going to look at prolapse, you can grade the prolapse, what's the pelvic floor tone, so you use the Oxford score grading system 0 to 5 really, from absolutely no awareness of pelvic floor tone, which actually can occur in up to half of women, right up to good pelvic floor tone and lift. Have they got perineal sensation, is there a degree of vaginal atrophy? You can observe for stress leakage in the supine position, and if they have it, that's actually a significant marker. You'll also look at what they're like coughing with a comfortably full bladder. That's not always easy to do in clinic because they may have just emptied, because you may have asked for them to have a urine dip or a post-mic residual. But you will look at urethral movement, and is there descent and rotation of the urethra, so the urethra descends in a rotating manner, and that shows a degree of hypermobility, or do they have a fixed urethra which is fairly lax at rest and fixed in an open position at the bladder neck, so that denotes a degree of what we used to call intrinsic sphincter deficiency. Or you'd get a urinalysis in the clinic, because what's their intercurrent UTI, is there a history of hematuria, and you'd also do a post-micturition bladder scan in the clinic if you can, because are they in retention, are we dealing with overflow incontinence? And then from there you may decide whether or not they need a cystoscopy. Have they got blood in the urine? Have they got bladder pain? Do you need any other imaging? Have they got high residuals, abnormal renal function? Do you need a renal tract? And then do you need urodynamics, or do you already know the answer?
Okay, so when would you want to do urodynamics?
So a lot of the times you don't need it actually. You know they've got stress incontinence, you're going to refer them on for conservative, or you know they've got urgency and overactivity, so you're going to refer them on you'll treat them there and then. But if you've previously tried incontinence surgery and it's failed, you might want a bit more of an idea of what's going on, or have you, because you've changed really the bladder neck mechanism and they may have developed something else. In some units, so it's a normal thing to have urodynamics prior to all surgery. It's not required for stress incontinence surgery, but there is some evidence to show that women who have stress incontinence with pre-existing overactive bladder and chooser overactivity won't do as well. So they'll be dry, but they'll have other symptoms on top. Whereas women who have pure stress incontinence and stable to choosers actually do very well with the operations. You will often do it in neuropathic patients because you don't know whether they have a normal functioning bladder with normal safe pressures, or do they have a poorly compliant bladder, so one that fills without relaxing naturally and the pressure goes up. When they've had previous vaginal surgery, or if they've got combined urinary incontinence and prolapse, you may want to try and figure out what's going on. There are certain classifications, so one we use, which was the Blavis and Olves classification. It's an older one really, and it actually looks at the position of the bladder neck at rest on video urodynamics continence. So this talks about the position of the inferior margin of the pubic symphysis in relation to the bladder neck and where it moves on coughing. And type 1, you've got normal position of the bladder neck above the symphysis, inferior margin of the symphysis pubis, and it's closed at rest. And when the patient coughs and they have the leak, there's a descent of less than 2 centimetres, so it doesn't move very far. Type 2A, which we call a urethral hypermobility, there's a normal position of the bladder neck above the inferior margin. It's closed at rest, and the descent is just that bit further. It's more than 2 centimetres, and you get urine leakage. Type 2B, again it's urethral hypermobility, we're talking about movement again. Again, the bladder neck's closed at rest, and the descent is greater than 2 centimetres below the inferior margin of the pubic symphysis, and then there's a degree of rotational descent. So a little bit of leak, a little bit of movement, and then a lot more movement and rotation. They're the types of urethral hypermobility. So type 3, which used to be called intrinsic sphincter deficiency, or ISD, bladder neck is open, fixed, it doesn't move, and it just leaks. So you've got movement and leak, or no movement, fixed open bladder neck and leak.
Okay, so what conservative things can we do for patients?
So often there's a lot of things you can do that don't involve drugs or surgery, and in urgency particularly you can do quite a lot with caffeine reduction. So there's lots of things that irritate the bladder, but there's good evidence to show that caffeine reduction improves urgency. It doesn't improve urgent continence, but certainly urgency. And if people are having huge volumes of fluid input and then huge volumes of voided output, sensible fluid management, so people only drink when they're thirsty and not just because they were told to consume a huge number of litres per day. And that can help a lot. If you can identify the pelvic floor and there's some muscle to work with, increasing pelvic floor muscle tone can help. But it's a muscle, it gets tired, patients need to continue to do it, and they need to do it 3 times a day, and they need to do it ongoing, or else that'll go back. For some people, surgery, drugs aren't an option, so they may have a vaginal pessary or a urethral insert. These are very unusual, and they're probably only in people who have maybe just extreme sport-related stress incontinence. So they don't want surgery, they only get wet when they run, so they'll have a sort of a special vaginal insert just to keep them dry for that, or during professional sporting activity. Or maybe the other extreme, where they're frail and elderly and they're not fit for surgery, or have had surgery and that's failed, and then you're talking about containment, so pads, or even a catheter.
So what are the medical options?
So the medical options are mainly for urgency incontinence, really. Simple things. If they've got vaginal atrophy, so the postmenopausal, even in the perimenopausal, the vaginal estrogens can help. Anticholinergics are drugs we've used for a long time and through all age groups, and they start with oxybutynin and then they go on to the more M selective, so the M2 and M3 selective anticholinergics like darafenicin, solifenicin. Then you've got other agents like trospium that don't cross the blood-brain barrier. You have to be cautious in the elderly because they do cause confusion, and then now there is some concerns about whether or not they bring on or unmask early dementia. So they're more of a drug for the younger population. You've got newer agents like the beta-3 agonist mirabegron, which don't have that concern, but do have the concern that they can elevate patients who have hypertension. So as long as that's monitored, it's a relatively safe drug. In stress urinary incontinence, you don't really have any medication other than duloxetine, which is an older SSRI. It does have some side effects, nausea, it can make people feel unwell. It's not first line, it's for people who can't have surgery, don't want to have surgery, and you don't really have any other option. But those drugs, anticholinergics, mirabegron, duloxetine you can use in both sexes.
And so what are the surgical options?
So if you're talking about stress urinary incontinence, you kind of want to know if it's hypermobility or intrinsic sphincter deficiency. Because if it's hypermobility, you're talking about supporting the bladder neck with a mid-urethral sling, or the tape that we used to call them. If it's a intrinsic sphincter deficiency, you're talking about augmenting that mechanism, so either bulking or an autologous sling or an artificial sphincter. Is there coexistent detrusor overactivity? Do you need to treat that first? Because if you don't, you could worsen that, and you probably will worsen that. Is there impaired detrusor contractility? Will the patient need to self-catheterize afterwards? So if you've got those questions in mind, then you may need to do urodynamics beforehand before you go down the route. Is there a prolapse? Do you need to treat the prolapse at the same time, or treat the prolapse first and then bring the patient back and treat the incontinence second? So if you're talking about stress urinary incontinence surgery, you've got simple things like bulking agents. So they increase coaptation of the urethral mucosas around the bladder neck mechanism. So urethral mucosas like that, doesn't close fully, you bulk in various areas and you get a better closure, so they create continence. They don't last forever, they may need repeated injections to get there, but they can be done under local anaesthetic, which is great for people who had previous surgery and can't have more surgery or are high risk. Then we've got the mid-urethral sling, so we've got the transvaginal sling, and we've got the Obturator sling, and you can see on the slide that the Obturator sling comes out through the obturator foramen in a different position to the obturator vessels. Has a higher risk of thigh pain and dyspareunia, whereas the transvaginal tape is a retropubic tape, and you can see it comes quite close to the bladder, so has a higher risk of bladder injury. Both of them have a degree of risk of infection and mesh erosion, but both of them will offer equivalence in that they will give an 80% improvement in symptoms, and half of the women will be completely dry. There's a mini sling, which is a much shorter one, which perforates the obturator foramen and hooks into there, but it doesn't go all the way through. We're not quite sure how that's going to work out yet. It's still in sort of experimental phase, so it's not something we offer here currently. If people have had previous surgery or they are reversed to mesh, you could talk about a colpose suspension, where you're taking the periurethral, perivaginal tissue, bringing it up and attaching it to Cooper's ligament, so you're elevating the bladder neck. If you're, again, averse to sling, or a patient who is at high risk of erosion, such as a neuropath, you could think about an autologous sling, where you either use cadaveric tissue or fascia lata tissue or rectus sheath tissue, and you create a sling with that, and you put it through like a retropubic tape, like a TVT. That has to go in quite tight under a bit of tension, and there's a high risk of having to self-catheterize with those patients, so it's not for everybody. And then there's the artificial urinary sphincter, which we don't put in very often for women in this country, but it's used in greater numbers overseas, particularly in France, which is very good for intrinsic sphincter deficiency, because you're replacing the entire mechanism with a new mechanism from the cuff. It does have a high risk of erosion, and obviously you have to have a switch that you have to activate to void.
So when we would do surgery for urge urinary incontinence?
So we talked about the drugs before. If the drugs don't work, or work but not enough, or patients can't get on with the drugs or have contraindications to the drugs, then you could think about botulinum toxin, which works to stabilise acetylcholinesterase release, so it doesn't get to act across the nerve terminal and cause a contraction. It also works on various sensory receptors, and that mechanism isn't fully understood. It's very good at treating urgency symptoms, particularly urge incontinence. We have sacral neural modulation, or sacral neural stimulation, where you have a pulse generator delivering a low voltage frequency around the S3 nerve, and that doesn't have the side effects that Botox has in terms of causing retention, and it does allow people to void who normally can't void due to poor relaxing sphincters, but it's an implant. So they both would have an improvement of 60 to 80% of urgency symptoms and incontinence episodes. One is a device that has to be implanted, but it has side effects. It has problems in that once you've got the device implanted, you can't then go in an MRI scanner, or you can't have monopolar diathermy. The device battery lasts 5 to 7 years and needs to be changed, so you could have local site infection, migration of the leads after any kind of minor trauma. The Botox can be given under a local anaesthetic, but needs to be repeated. Only lasts between 6 and 9 months, and does increase your risk of urinary infections because of instrumentation and the fact that you may be retaining some volume of urine. The higher the dose of Botox, the more the retention and the higher your chance of self-catheterizing. Posterior tibial nerve stimulation isn't quite there in terms of the data as to the others, but it may be an option for those not fit for sacral neurostimulation, or because maybe they have a neurological condition and they'll need to be continually MRI'd and they don't like the thought of self-catheterizing, so Botox isn't for them. So there may be a role for PTNS there. Augmentation cystoplasty, where you bivalve the bladder and then put a patch of small bowel over the top to increase the capacity and depower the bladder, is a much older procedure, and is therefore for those with refractory urgency and overactivity that has failed to respond to the lesser invasive measures, really. In some women who have an unstable or overactive bladder and urgency with intercurrent prolapse, there is an argument to repair the prolapse first, which is part of Olmstein's integral theory, so that repairing the bladder floor and repairing the anterior vaginal wall stabilises the bladder and improves the urgency, and then they could be reassessed to see whether they need further treatment. I think that covers everything, Pete.